A warm welcome to you, ladies and gentlemen, to the 40th session of Learn from the Legends, an international bi-monthly webinar series organized by National Neonatology Forum, Kerala, and Indian Academy of Pediatrics Neonatology chapter. I have great pleasure to welcome our esteemed faculty today, Professor Francis Cowan, visiting Professor, Department of Neonatal Neuroscience, University of Bristol, UK, and Imperial College London. And her topic would be neonatal stroke. We have two eminent moderators tonight, Dr. Ramesh Chowdhury from Jaipur, Dr. Rajendra Prasad from Hyderabad. A warm welcome to each and every one of you. Over to Dr. V.C. Manoj. Thank you.
Hello everyone. Hearty welcome to the 40th session of our Learn from the Legends series. We have today a very distinguished person as the expert who is going to talk to us about neonatal stroke. Yes, it's none other than Professor Francis Cowan. Francis Cowan is a honorary senior clinical consultant in perinatal neurology at Imperial College London and a visiting professor to the Department of Neonatal Neuroscience in the University of Bristol, UK. She studied medicine in Dublin, Ireland, qualifying in 1972 and went on to specialize in pediatrics and neonatology in UK. Her research in neonatal physiology with Professor Kenneth Cross in London led to a PhD award in Oslo, Norway on neonatal cerebral blood flow assessed during Doppler techniques. She then went on to work at Hammersmith Hospital, Imperial College London with Dr. Lily Dubowitz and others in neonatal neurology, cranial ultrasound, MRI imaging and neurodevelopmental follow-up. Professor Cowan is particularly interested in perinatal brain injury, its timing and risk factors, patterns of injury, and the evolution and the early determination of prognosis. Her focus always has been both the prediction of normality and severity of neurologic abnormality, minimizing the uncertainty for parents. She is a very, very caring physician, I must say. Professor Cowan is now retired from clinical work, but her passion teaching did not allow her to actually retire. She continues to teach and is involved in brain image reporting and academic supervision. With others, she also run an annual course in cranial ultrasound imaging we have all heard of. Professor Cowan has also helped to develop and run a website providing information on Hammersmith neonatal and infant neurology examination, which we all do every day, making them more readily and freely available worldwide. We are really thankful to Professor Cowan for having agreed to deliver this lecture. And with this lecture, we move on to neonatal neurology. Once again, we drift from topic to another, one topic to another. So today it is going to be neonatal stroke. And ladies and gentlemen, let's welcome the Professor Francis Cowan. Over to you, Professor Cowan.
Okay, I hope you can all see my screen.
Yes, ma'am.
Thank you very much for the invitation. It's a great honor. And the 40th is quite a number that you've reached. And it's very impressive. So I hope I can add to the information that has been imparted by my predecessors. And I hope this will be of interest to you. Oh, wait a minute. Okay, hang on. Yeah, okay. So neonatal stroke or perinatal stroke, I'll discuss that terminology in a minute. But although people think that stroke is a problem of the elderly, it actually is this is a very focused period of risk for stroke the week that you're being born. The rate of stroke in this week is high compared to the rate over time in children. And the risk at any given time point is not in this week is not dissimilar to that seen in older adults. And perinatal stroke is a cause of severe lifelong morbidity. And that's often despite relatively good early development. It occurs in about 1 in 2,500 to 3,000 term-born infants, though these numbers vary a bit in different studies. And the one study focused on preterms reported an incidence of 1 in 100 preterms in an intensive neonatal unit. SORG found the similar numbers to those that are born at term. Although we think we know quite a lot about it, still there remain challenges. The cause is often unclear. We don't have any reliable way to prevent it happening. The exact timing can be unclear, and we don't have any specific acute treatment as yet. The outcome is relatively predictable for some aspects of development, but can we modify it? Can we improve outcome? We are maybe beginning on that, but we have a long way to go. So definitions, well, neonatal stroke and perinatal stroke are often used interchangeably, but as you know, the perinatal period goes from about 28 weeks of gestation through to a week after birth. And the neonatal period goes from birth to 28 days. So there's clearly a period around the time of birth where you could call a stroke a neonatal or a perinatal stroke. But perinatal stroke tends to include those lesions that have occurred preterm or antenatally, whereas the neonatal ones go on to a month and may include more lesions that are related to infection or collapse or maybe cardiac disease. And then we have a group of called presumed perinatal stroke, where a stroke is detected later in the first few months after birth. And it looks as if it's the same sort of lesion as we know occurs around birth, but there were no apparent symptoms at birth, and the child presents with problems in the first few months. And this tends to be called presumed perinatal stroke, and is sort of assumed to be of the same kind of etiology as strokes that occur around this time. So today we'll really concentrate on neonatal arterial stroke or perinatal arterial stroke, which could be in a term-born infant or in a preterm-born infant. There are other strokes. There's acute focal hemorrhagic stroke, stroke associated with sinus venous thrombosis. And those presenting later may be similar to this, but nowadays called APIS. You can have a presumed perinatal hemorrhagic stroke that appears later, or a periventricular venous infarction that presents with symptoms later on. But we will concentrate on this lesion here. Just to give you a taste, this is a stroke. You can see on this MRI scan, there's an area of abnormal signal on the right here, and you see it better on the T2 weighted image. And here it is at day 5, a bit easier to see, especially on the T2. And by day 12, you're beginning to get some atrophy or contraction of the tissue very quickly. And then if you had a child who presented with a mild hemi, say at 3 months, and you did a scan that looked like this, then you would say, well, I presume it happened at birth, and now it looks like this. But often these children are not scanned until maybe they're 9 or 12 months old, and then it's very difficult to go back and say exactly when you thought the stroke may have occurred. But this is how it looks like acutely, and this is how it looks like by 3 months or so here. This lesion, NACE or PAS, does not include so-called watershed lesions where you have injury going across arterial territories. It doesn't include venous infarction where you have an outpouching from the ventricle as if it was a preterm infant that had a periventricular hemorrhage. And it doesn't include large isolated focal hemorrhage, which often doesn't stick to arterial territories. Hemorrhagic stroke then, whilst it in an adult would be included in stroke, is actually not included under this heading. There's been a few papers recently on the topic, and you see they tend to occur in slightly different sites, for the whole of the thalamus, or here, well, this one is within an arterial territory, but and this one too. This one is crossing territories, but the predominant feature is hemorrhage. And in a fairly recent study, they found that they didn't find any cause and they didn't think it was an arterial territory stroke in a third of them. They thought there was hemorrhage into some unusual ischemic lesion in a third. Some were associated with cerebral venous thrombosis, which is always important to think of. Some were in children who presented with hypoxic ischemic encephalopathy, although that's not that common. And only a very few were actually thought to be a true neonatal arterial territory stroke. However, these lesions have a male predominance, as most stroke does in childhood. And the outcomes are related, as in stroke, to the site of the lesion, but also to whatever the underlying problem was that may have led to the hemorrhage, if that was ascertainable. But for neonatal or perinatal stroke, there's an innate susceptibility for that because the fetus has a high hemoglobin and packed cell volume, so the blood flow is relatively slow, and pregnancy is a hypercoagulable state, especially towards the end. So both the mother and the baby are at increased risk. And it's mainly thought that thromboembolism from the placenta access the cerebral circulation through the patent foramen ovale. There are a few reports that thrombotic lesions may break off from or cause obstruction in the neck vessels or the arteries in the neck due to rotation at delivery, but these are very few reports that are in the literature. So in addition to this general background risk, specific risk factors are twin-to-twin transfusion, where it's obvious that you may have an increased risk of emboli entering one or other baby. Systemic lupus in the mother increases the risk. Cocaine abuse is reported, although I don't think the data is very strong. And maternal collapse and trauma may affect the blood supply to the fetus. And if you have a baby with a fetal acidosis and pulmonary hypertension allowing the fetal circulation to persist, if there are emboli sitting in the vena cava or the liver, then they have an increased length of time when they may access the cerebral circulation. Of course, congenital heart disease is a risk, sepsis of any sort is a risk, and background DIC and polycythemia. And particularly in PREMS, vascular cannulation or with ECMO, and hypoglycemia has been reported, although the mechanism by which that works isn't really understood. And then there have, of course, been suggestions that perinatal asphyxia is a risk factor, although for quite a long time that was not really taken very seriously, and perhaps birth trauma. But for most term babies who have a stroke, these items are not common to find. It's not the usual thing that you find some underlying reason like in this list here that is related to the stroke. Most babies do not have these factors. As I said, we think that the main reason is that you get an embolus coming from the placenta, which maybe sits in the vasculature here or in the heart, or goes directly to the brain then, or goes to the brain during the process of birth. even after the cord is clamped, or if there's a delay in cord clamping, it is a bit of a worry that you may increase the risk of something entering the heart and accessing the cerebral circulation. Stroke is more common on the left side, and we don't really know why, the presumption being that access is straighter on the left side than up here, rather than going to the right side, but there's no actual proof of that. So risk factors, can we find any single risk factor other than these lists that I've mentioned that generally are not relevant in your particular child? Well, we know that being male is a risk factor. And the other areas we can look at are, is there a family history? Is the mother got some illness? Are there factors in labor and delivery, or earlier in the pregnancy, or are there postnatal factors? And generally speaking, studies have shown, I'll just go into this male business. We don't really understand why male susceptibility is present. It might simply be a factor related to weight and size and head circumference. But the interaction between maternal and fetal factors may lead to more thrombosis in males. Male umbilical cord endothelial cells may synthesize more prostaglandin, prostacyclin and prostaglandin E than females when exposed to thrombin, and increase the risk of obstruction. Males may lack neuroprotective effects of estrogen that females have, and testosterone may enhance glutamate activity. All these are rather theoretical, and we don't know exactly why males are more susceptible. We tried to look at risk factors, and we found, as others have suggested, in a large case control study with 79 symptomatic term babies with stroke and 239 term controls, that males were more susceptible. We found that a family history of seizures and neurological disease, whatever, increased the risk, but we don't know the mechanism. And we found that having 2 or more intrapartum factors that we looked at increased the risk. And if you had no risk factors, that we took a huge long list of possible risk factors, the controls had no risk factors more often than the cases. The cases had slightly more of one factor than controls, and then 2 factors, 3 factors, 4 factors. The cases certainly had 4 factors more often than controls, and 3 factors too. But of course, there were relatively few infants that fell into those categories. And this supports data from other studies. What about the role of hypoxia ischemia? Well, several studies have supported the fact that stroke occurs a bit more commonly than you would expect with hypoxic ischemic encephalopathy, or with suspected perinatal asphyxia. That's generally accepted. And when we compared our 79 symptomatic term infants with the controls and with 400 HIE term infants, we found that the HIE infants and the stroke infants had similar increased amounts of risk factors. But in the stroke infants, pyrexia was more common than in the HIE infants. Prolonged rupture of membranes was more common in the stroke infants than HIE infants, and also prolonged second stage. Possibly a tight nuchal cord, and then a failed instrumental delivery, which went along with the prolonged second stage. What we found that other risk factors that were more related to sentinel events and acute events were more common in the HIE infants than the stroke infants. Additionally, we know that these factors, fever, and placental abnormalities of chorioamnionitis, and we know sepsis and meningitis, increase the risk of stroke. And we know also that children who have stroke, young children, often have a history of a viral infection, an upper respiratory infection or mycoplasma and so on. They're all more common background factors to stroke. And there have been elegant studies by Sabir looking at the role of inflammation in stroke. And I won't go into this in detail, but this is, of course, rat studies. They find that maternal infection and inflammation with chorioamnionitis increases the risk of the fetal inflammatory response, a pro-collaborative state, and these lead to an increased risk of stroke. And they think that the neurons are sensitized by these inflammatory processes that makes them more vulnerable. In a study of the placenta, and there are not many such studies because often the placenta is thrown away before the child becomes symptomatic. Again, phenicitis and chorioamnionitis, villitis, and also placental infarcts were all found more commonly in children who had stroke than those that didn't. And in an elegant study from Michael Rifkin's group, they found on the placenta, they found that if you had 2 or more of 5 categories of different placental abnormalities, you were much more likely to be in the stroke group than in the control group. And again, if you had vascular malperfusion, inflammation, and a stress response with meconium, these all occurred more commonly with stroke. So there seems to be evidence from the placenta that both inflammation and some evidence of hypoxia are risk factors for stroke. And this sort of puts that together, that hypoxia, ischemia, increases activated protein C and S and antithrombin. Infection and inflammation will release cytokines and cause endothelial injury, and chorioamnionitis all come together to increase the risk of thromboembolism. But it's not surprising, perhaps, that there isn't one risk factor. We think that there is this shared factors between HIE and NACE, with inflammation and mild asphyxia playing strong roles in a susceptible, often small male, and more often a primate mother. And it's of interest, although I'm not suggesting this is a way to go forward, that stroke is very uncommon after elective cesarean section. It's very rare to find that. So somehow avoiding the whole process of labor and delivery when this mild asphyxia or inflammatory factors may have a time to affect the fetus is protective, but we don't quite understand. And I'm not suggesting that everyone should be delivered by elective cesarean section. At one time, it was thought that thrombotic factors played a great role, and there were several studies that suggested this, looking at many different factors. We did one with factor V Leiden and the prothrombin mutation gene. But this hasn't, I think in recent years where people have done these tests more and more, there's less feeling that this is playing a major role. And recently, or relatively recently, Curtis et al. From Canada did a prospective study of over 200 infants with different stroke-like lesions. They suggest, the results of this suggested that there was a minimal association between perinatal stroke and thrombophilia. They didn't totally exclude the possibility, but they suggested that testing every child was not really indicated. And I think the hematologists are rather relieved to have this paper out. And this paper by Arnes later supported that data. But if you have an atypically appearing stroke, a stroke with some developmental abnormality, a stroke with a hemorrhage, or established atrophy already, consider genetic and hematological diagnosis. All would be rare, but can think about it. Or COL4A1 or A2 deficiencies may present with stroke. although not usually a typical arterial territory stroke. Some neurocutaneous disorder like incontinence pigmenti can have stroke-like lesions, and some metabolic disorders. So just keep that in the back of your mind. Stroke, we talk mainly about full-term babies, but it certainly occurs in preterms. As I mentioned earlier in this study from the Dutch by Benders, the site is more likely to be central grey matter than peripheral, and risk factors are, not surprisingly, twin-to-twin transfusion, but also reduced fetal movements, abnormal fetal heart rate, and hypoglycemia. And why that is, it is not clear. And you see that the stroke is likely to be a main branch arterial territory stroke in the more mature preterm infant, but as you get down in weeks, they're more likely to be central lenticulostriate strokes, and I'll show some images in a minute. Early symptoms, well, seizures are the classical presentation between day 1 and day 3, usually after a fairly normal condition at birth. They may be unilateral, but not all babies have seizures, and some may just be floppy, not feeding, quiet, so consider this. Preterms, their strokes are often found incidentally on routine cranial ultrasound, although they may have a large lesion, which has been found early. Postnatal management, I think it's really important to maintain blood pressure and normal gases, avoid hypothermia at all costs and hypoglycemia, and hypocarbia, which may cause vascular constriction. Clearly look for infection and sources of emboli. Treat the seizures, whether clinical or subclinical. I think we're generally agreed on that now. And look for other possible causes of stroke in the list I've just given: lactate measures, family history, any dysmorphisms or evidence of arteriopathies. Do an early cranial ultrasound, not that you will necessarily see the stroke on that, but to exclude any structural or anatomical abnormality or clue to another diagnosis, and ideally get an early EEG, or at least put a cerebral function monitor on. And on your early ultrasound, in the first day or so, you may not see anything. That does not exclude a diagnosis of stroke. So go back after a day or two and re-scan. But if the early signs are often just some swelling of the cortical outline, like here, you see here it's very clear. Here you see it's rather blurry and a bit more echogenic than it should be. But on this scan, you don't see much else, maybe a little bit of echogenicity in the central grey matter. As we scan further back, actually, in this child, we see a little more. And we see on the parasagittal view some echogenicity. But unless you're looking for this, you may miss it. And this was a MCA territory stroke. And you see on the MRI a large area of stroke here on the diffusion and here at 3 months. Typical strokes, if they're full MCA territory stroke, that is obstructing the MCA vessel here and causing lack of blood flow in all this tissue, will give you a sort of wedge-shaped lesion. So you see the sort of edges, you see a wedge-shaped area of echogenicity. Here it's not fully evolved yet because you still see some detail of the tissue. And we also see that the central grey matter is involved here. So that suggests the obstruction is here and not after the lenticulostriate vessels. And you may need to tilt your scan to see this area well if you want to go right out to the edge. And you see here there's a full MCA territory stroke in this child. On the other hand, the lesions might be quite subtle. And for example, here you might, well, I'm sure you would notice something because I'm giving you this picture, but it might be easy to miss while you're doing a scan through the whole brain. But here we see that there's an area of echogenicity equivalent to an area of tissue injury related to a posterior branch of the more distal MCA. You can also get stroke in the central grey matter related to any of these vessels that go through the basal ganglia and thalami. And for example, here's one in a preterm infant. Here you see an area of stroke. They're usually rather clean and they can be sort of wedge shaped like this, and correlates very well with the MR imaging done not too long later. Strokes occur not just in the middle cerebral artery territory, but also anterior in this area of tissue along the midline. So you see here echogenicity going up the midline here and here. And you see this is 3, 4 MRI on day 30, 4 weeks later, you see already you've got really obvious atrophy of the area of affected tissue. And a posterior cerebral artery territory stroke, they're more difficult to see unless you angle back and look for them or scan through the posterior fontanelle. But think of it always, and you see this increased echogenicity on the right here, equivalent to this area of abnormality on the MRI. But you might easily miss this, especially if the baby's got a small fontanelle and thick hair and you're not got a scanner that's going to penetrate far into the back here. So think of that, they're not that common. It's important to do a scan on admission, and this is an example of a baby who was born at 35 weeks, and the admission scan showed this very clear wedge-shaped area of abnormality here and here, clearly MCA territory stroke. And if there hadn't been a scan on admission, you wouldn't have known that it was clearly antenatal in origin. This was at 2 to 3 weeks, this large area of atrophic tissue. Actually, this mother did take cocaine, and whether that was anything to do with it or not, I don't know, but it clearly happened sometime before delivery, at least some days or a week or so. So how do we go about looking at these and predicting outcome? Clearly, imaging is the way to go for diagnosis, and your ultrasound and the MRI are both very helpful. And looking at the MRI, we noticed many years ago that if you had the hemisphere involved in the stroke, the basal ganglia and the internal capsule here, you would develop a hemiplegia. So it's important when you're looking at the internal capsule to look at this part, not up by the genu here and not right at the back, but this part. And if that's involved, it really increases the risk of stroke or leading to hemiplegia. More elegant studies were done when diffusion weighted imaging was the rule, and you could see diffusion changes in the corticospinal tracts and reduced ADC values, and later established Wallerian degeneration. All these things were associated with hemiplegia. And you see here, this is the conventional T1 weighted image. We can see the stroke area here, but we're not quite sure whether the internal capsule, this looks normal, but whether this is involved or not. The basal ganglia is clearly not normal. But when we do the diffusion image, we can see that there's abnormal diffusion within the internal capsule. And also lower down, we can see that there are diffusion changes, changes on the T2, but very clearly changes in the peduncle. And this will lead to the development of a hemiplegia. So we can predict motor outcome relatively well. I think when to image is in general, as soon as you think of the diagnosis of stroke, it minimizes your other investigations, it gives you a diagnosis and allows you to maximize information about the timing of the lesion. However, there are 1 or 2 reports that very early imaging may be a bit too early to see the full extent of the stroke. So it's not important to do it on day 1, but I think you're not going to miss the diagnosis by early, but you may not see the full extent of the lesion. So we did a study looking at outcome related to different types of stroke. Here's a full MCA territory stroke. Here's an anterior branch, a middle branch, and a posterior branch. And here's just a cortical stroke, central grey matter, lenticulostriate stroke, posterior cerebral artery and anterior cerebral artery. And we looked at the outcome at 2 to 3 years in a large number of children, that we had 158 children. So it's well known that after stroke, about a third of children develop a hemiplegia. But that's difficult information to give parents when you could say to them, if your child has a stroke like this, we know your child will develop a hemiplegia, it's 100%. But if you had an anterior branch only, it's only 6%. The middle, 15%, and more posterior, it's 21%. And I can't see what's under here at the moment, but cognitive delay was 50% of the main branch, but much smaller numbers for the smaller territory strokes. The same pattern for behavioral problems. Visual defects were really only in strokes that involved this posterior part. So either the posterior or a main branch that involved that. And there were a considerable number of children, like 81% of these children had a normal outcome at this time, 54% of these children, and 65 to 70% of these. So you can be much more informative to parents and therapists and about the likelihood of many aspects of development from looking at the site of the lesion. We also looked at the perforator branch, the posterior and anterior. And you see here, very few of these children will develop cerebral palsy, only if this lesion impinges and really affects the internal capsule. And very few have these other problems. Slightly more so, we put these together because we didn't have large numbers, but still much less in the way of problems than the main branch. So I think this is a very important type of data when you're counseling parents. And then later outcomes. Well, in a study we did, most of the children, 75% of children with stroke, had an outcome, had an FIQ in the normal range at 5 to 7 years, but it was lower than peers. And we know that cognitive function may worsen over time, especially if seizures are an issue. We noted that verbal scores are lower and more variable than performance scores. And actually, one of the unseen issues with stroke is that children may have more problem with language than we realize. They talk well, but whether they have a flexibility and choice of how they make sentences, it's not as good as their peers. We didn't find a consistent association between side and extent of lesion. We found that children with low IQ did have other problems, behavioral problems, low family IQ, maybe very mild dysmorphisms. There is now a report that there's an increased risk of autism with perinatal stroke, and it seemed to cover all sizes and types, but there wasn't imaging detail in the paper. And visual problems are probably, visuospatial problems are probably more common than earlier reported. But there are other issues. Schools and social groups and even families may not appreciate non-visible disabilities, and the children, they don't understand how difficult it is for these children to just manage daily activities. There's a lot of peer pressure. They feel very sensitive about how different they are from other children in school, because most of these children are in mainstream school, and importantly, most of these children are walking. And having summer camps where children can go and meet other children with stroke and understand that there are other people in the world like them and have special tasks that they can learn to do has in many different places proved extremely beneficial. What about treatments? Well, acute treatments, apart from what I listed before, there aren't any as yet. There's a study on erythropoietin. We know that that can have, in some animal work, improved cell survival and long-term effects. I won't go into the detail. And there in rats with stroke, they've shown that 3 doses of erythropoietin improved outcome. And in another study, they've shown that EPO after a week reduced the size of tissue loss, and there was an improved outcome after 4 weeks. So there is a study called RCT EPO, a dinosaur study, going on in Holland at the moment, and they are recruiting up to about next year, and then they should have 18-month outcomes by 2004. And they're giving EPO to children with an MR confirmed stroke. But the data is not available yet. And similarly, there's a study on stem cells called PASSION, which is also going on in Holland, in Utrecht. And they're just finishing this safety study, and it, I think, has been shown to be safe. There's been no untoward side effects. And there may be a suggestion that there is some improved outcome, but the number of children is extremely small. So it's really not powered to look at that. But it will lead, I hope, to a larger study on giving stroke. They give them through the nose several times in the first week. It's important to know this diagnosis because actually therapies like CIMT, constrained induced movement therapy, has been shown to be useful. And that's where you limit the use of the unaffected limb and encourage the child for a few hours a day to use the affected limb. Equally, there's data that showing that encouraging bimanual therapy early on is also helpful, and these two approaches can be used together. So I think that is some help. And Adam Curtin in Canada is testing out the use of transmagnetic stimulation, which also may be a helpful approach to improve function. And as a background approach, this study by the group in Australia, Kathy Morgan, on this enriched environment called GAME, has also been shown to help children's early development. And then there's eTips, which Anna Basu has developed in the north of England, Newcastle, where they have an online video and feedback approach with parents to help them manage the baby and show them what to do next. So all these are approaches that I think may really prove helpful and really can need an early diagnosis to institute. So there are many things that can influence brain development after stroke, and maybe therapy and neuromodulation experience is a positive one, but maybe your genetics are against you. Family support can be good or bad, and epilepsy and sleep disruption seem to be negative effects on development. So both in the first years after birth, but also later, children have been shown to make functional gains. And how much gain they make may depend on what they've had before, and how much reorganization can take place in the other hemisphere, and whether there's been secondary atrophy of the thalamus and cerebellar size. And a lot of work remains to be done on understanding this. So remember that after stroke, it's not only motor problems. Almost all children with stroke will walk, even if it's not a normal gait. It may be a bit later, but most will walk. But they have substantial difficulties in many other areas of development, and particularly if they have epilepsy. And as they grow, the effects of peer pressure become more in the sensitive teenage child. It's much more of an issue than in the young child when we are really testing them. And maternal guilt and blame is common and been well reported by the Canadians, and needs to be something that should be thought about. It's important to inform the family, engage them in helping their child. And there are now, which I've listed, some support organizations. I'm afraid I don't know the names of any in your part of the world, but I'm sure there are some, but these are accessible to everybody. We have no clear preventative factors, but perhaps avoiding long and difficult labors may lessen the incidence of stroke. So this is just a summary of that. I perhaps won't repeat it because I'm running over time a bit, but we have a long way to go in understanding why children develop stroke and in terms of prevention. It's helpful to collect detailed perinatal data, always to try and increase our knowledge of the background information in children who have stroke. Underlying metabolic and genetic associations are uncommon, but should be thought about. Good perinatal imaging is really the key for prediction. It excludes other problems, and it really does allow you to focus what early therapy you may have when you know what the likelihood is of particular outcomes. And further studies understanding how the brain develops after stroke are really important and should help further interventions and knowledge and so on. Thank you very much. Hello?
Thank you so much, Professor Kawan, for lecture. Now it's a time for question answer session. So I have the pleasure to introduce the moderators for today. Dr. Ramesh Chowdhury from Jaipur and Dr. Rajendra Prasad from Hyderabad. Over to you, moderators. Dr. Ramesh and Dr. Rajendra.
Thank you. Thanks for the excellent presentation. So we have some questions in the chat box. So he tells, I just wonder the role of cerebral NIRS in early suspicion of stroke in babies with seizures. So they're asking what is the role of NIRS in neonates where there are seizures and we are suspecting stroke.
What is the role of NIRS? Is that what you said?
Yes.
Yeah, NIRS.
Yes.
Well, you may see clearly differences between the sides if you're looking at two sides with NIRS. I don't think it's been shown. I mean, it has been shown in HIE, a more global insult, to be helpful in understanding the severity of the early insult, but I don't think that that has been shown in stroke. And I don't know that, I don't think that NIRS has been shown to make a big difference in terms of, it might give you an indication of a diagnosis if you have some asymmetry, but I don't think it's more helpful than imaging or clinical presentation and EEG. When you do an EEG, it's if you're using a CFM, you want to have two, especially if you have a child with asymmetrical seizures, it's sensible to put the CFM on both hemispheres or move it from one to the other if you only have one probe to see whether there's a difference between the sides.
So that answers the question. NIRS doesn't have a role in diagnosis of stroke. Rather, we should employ use of EEG. So the next question over to Dr. Ramesh.
One more question. That's regarding the use of erythropoietin in the preterm neonates with intraventricular hemorrhage. And is there any role of early hydrocortisone at low doses in the same neonates?
In hydrocortisone or erythropoietin?
Yeah. In the preterm neonates with intraventricular hemorrhage.
I don't think people are using hydrocortisone in preterm IVH. No, I don't think that there's a role. In fact, I don't think there was a time when indomethacin was given as a preventative. Erythropoietin is being trialed, I think, but I don't think it's been used. Well, I'm not particularly up in that, but I don't think it's been used as a regular medication. If you asked about erythropoietin, I couldn't quite hear you.
Yeah.
But not hydrocortisone, no. Unless you're using it to control blood pressure. I mean, that's a different issue. Maybe.
That's all.
Yeah.
So, is there any role of erythropoietin in the IVH?
Erythropoietin.
Yeah.
Yes. Well, as I said, I think there's a group that is studying this, but I don't think that it has come into standard usage.
Okay. Thank you.
One more question from Dr. Yolanda Prevost. So, what is the role of anticonvulsant therapy when we when we are suspecting stroke and cranial ultrasound shows a big lesion? So,
Is there a role for giving anticonvulsants straight away?
Straight away without seizure?
Well, certainly you should give excuse me. Yes, I think you should definitely treat seizures, and you should treat them even if they're subclinical, so you don't see anything. I think that the evidence is never terribly strong, but the evidence is more for treating than not treating. And the more you have seizures, the more you put metabolic demands on the tissue, which is not what you want to do at this time. So I think there's no doubt that you should treat seizures, and you should treat them for a few days until they are certain they've stopped. But I don't think that there's a place for, unless you have an unusual lesion or a baby with, with other problems, I don't think you should be sending children home on anticonvulsants when they're clearly not had any seizures for a few days. I don't think there's evidence to support that. It's good to give parents education about seizures so that if they suspect them happening again, they come and see someone quickly. But putting all children with stroke on regular anticonvulsants over several months is not to be recommended.
One more question from the Levert Mamani. That's regarding the use of stem cell treatment in the neonatal stroke.
Mm-hmm.
Is there any experience with your clinical practice?
Oh, no. I mean, this is one trial in one country that's going on in stroke.
Okay.
So I don't personally have any experience. And they're only at the stage of, I think they've given stem cells to 10 children.
Okay. You are not contacted with the team?
Sorry?
You are not in contact with the team?
Yes, I am. But that what they have said is that they have no side effects that they have found, and they have imaged, and they haven't seen any negative findings on their imaging that would be against giving stem cells, and they are at a stage to want to proceed to a much larger study. But this was really a safety study.
Okay.
Yeah.
One more question from the same participant. That's regarding the colostrum use via the nasal route.
In cases of hemorrhagic stroke, is there any role of giving the?
Yeah, colostrum. Yes, I don't think they're using colostrum. I know that that has been used, I think, in preterms. I have to say I'm not quite sure. And you can get stem cells and so on, but I don't think in this study they're using stem cells. Colostrum. And I don't know of any study in stroke that's using colostrum. At least I'm not able to give information about it.
So I would like to ask one more question on the behalf of the attendees. Is there any role for anticoagulation therapy and antifibrinolytics? Anticoagulation therapy and antifibrinolytics.
Sorry, a question on anticoagulation?
Yes, anticoagulation and antifibrinolytics.
Well, I think in neonates, the only, in this group of disorders, the indication for anticoagulation is if you have evidence of cerebral venous thrombosis, which you generally don't with stroke. But if you had a hemorrhagic stroke or the stroke was in an unusual site, and you did studies, either Doppler studies with your ultrasound or an venography with your MRI, and you felt that there was a venous thrombosis, then I think that there would be a very good case for giving anticoagulation or low molecular weight heparin. It certainly has been done in neonatal CSVT and has seemed to be safe, even with children with quite large hemorrhage. But particularly with CSVT, the child tends to present with an IVH and maybe thalamic hemorrhage rather than an arterial territory stroke. But it's not recommended for the standard arterial territory stroke. I found an article that's just published where they described actually removing a clot surgically from a blocked middle cerebral artery territory. I forget which country that is, some Eastern European country, sorry, I forget. And they were successful. I mean, the operation went successfully. Unfortunately, the imaging before was a CT, and it was a bit difficult to tell the extent of tissue involvement. And the imaging after was an MRI, and you could see the internal capsules then, but it wasn't clear that you couldn't before. So I don't know whether it really made a big difference to the size of the stroke or not, because the child clearly still had a stroke, but it may have been smaller than it might have been. But that was an interesting approach, and their one child that they tried this in, it was successful from a practical point of view.
Okay, one more question. That's regarding the incidence of stroke in metabolic disorders, and what are the areas usually affected?
Well, this is all extremely rare, so I don't think there's really data on the incidence, but it's certainly not high in the neonatal, like Lee's disease, some mitochondrial disorder, so on. They would tend to be more central than peripheral, but they could be peripheral. But classically with these disorders, you look in the central gray matter for abnormality.
So in neonates with arterial ischemic stroke, is there any role for testing the thrombophilic state? So is there any special situation where you would recommend doing such an investigation?
To do the thrombophilic investigations?
Yes, yes.
Yes. Well, I think if you have a strong family history, if the mother has had symptoms of thrombosis in pregnancy herself, if there are evidence of thrombosis in other parts of the child, like a limb or so on, I would certainly do it. And if there's evidence of thrombosis in a central vessel in the brain as well, I would do it. So in those sort of circumstances, I would undertake it. But I think for the child with a clear-cut MCA territory stroke and no other problem and no family history, the child who doesn't look unusual, the child, I would do it also in a child with a cerebellar problem as well, because that makes you think of COL 41A or 41B, or then I would do it, but not routinely anymore.
One more question about cranial ultrasound. In a suspected neonatal ischemic stroke, it is easy to miss the lesions on ultrasound, especially in the early phase. So are there any important or key areas which should be focused and looked into while doing ultrasound?
Yeah. Well, of course, the commonest site of stroke is the left middle cerebral artery territory. So you really want to compare sides very carefully and don't dismiss minor echogenicity. And you want to look, very rather at subtle changes in the cortex, and also subtle, rather diffuse echogenicity within the one basal ganglia. And then don't forget to have a quick look for the frontal region, as I showed you, and posteriorly. But if you really don't see anything, then the stroke must have been recent. And I think you just need to scan again the next day, or at the most 2 days later. And in a study that we did, we found on the first scan that was done in the first few days, so most of these children don't present till the end of the first day, say, so you're not scanning till that time anyway. We found that 2/3 of the children had some abnormality on their scan. And then when we compared that to the scans that were taken from day 4 to day 10, there nearly 90% had some abnormality on the scan. So, and what we didn't miss any large strokes. Of course, we missed the diagnosis. We would have missed the diagnosis, but we didn't actually miss large strokes. We saw all of those on the ultrasound. And the ones that we didn't see were smaller posterior MCA territory strokes or posterior strokes. But none of those children where we missed a stroke had developed a hemiplegia. So we did see evidence of stroke in all the children who developed a hemiplegia. And there was recently a paper from the Spanish, and I just now forget Arnes, I think, the first author, and they did a study comparing relatively amateur people, not amateurs, I mean, they were all medical, but they were not so experienced, with experienced ultrasonographers for MCA territory stroke. And they were up in over 90% detection on the first scan, or the first to second scan that they did. So I think it's fairly reliable.
Thank you, Professor Kovan, for such nice presentation and excellently answering all the questions. So as we have run out of time, we would like to conclude this session. And just to summarize for all the listeners, if we talk about neonatal arterial ischemic stroke, neonatal age group has the highest risk compared to any other age. And neonates are inherently predisposed to stroke because they have a hypercoagulable state, and there is an open right to left shunt in form of foramen ovale, and they have a rich source of emboli from placenta and involuting vessels. So in most term babies, as Professor Francis has pointed out, there are no risk factors. Thrombophilia testing is not recommended when it is just an arterial ischemic stroke. It is only recommended if there is a family history or multiple vessel involvement, or that it is a venous cerebral venous thrombosis. And the most common lesion is left MCA. And MRI is the diagnostic modality of choice. If you want to know the extent, you may better delay it by around 48 hours. It has an excellent prognostic value, and it is useful in counseling the family members. And the early trials with EPO and stem cells show encouraging results, but the final results are still awaited. It is important to make an early diagnosis because the early developmental interventions, they will be of paramount importance to the child and the family. Over to Dr. Manoj for further comments.
Thank you, Rajendra. Ladies and gentlemen, we are coming to the end of this great lecture. From the bottom of my heart, on my behalf, and on the team Learn from the Legends, we would like to thank Professor Francis Kovan. Madam has been kind enough to spare a time to give an elegant lecture on a topic that is not so familiar to all of us, and then a lot of gray areas in the topic which and I'm sure that some of the areas have been, some sensitization has been done with her lecture. Thank you, madam, for inspiring us to know more about this. Thank you so much. And we would humbly request you again to join us for the grand final in March, also in the series. We would get in touch with you for that. Thank you so much, ma'am.
Thank you for inviting me. It was
Thank you.
a pleasure.
Thank you. Thank you.
Thank you.
I would
Bye
also
bye.
like, thank you, ma'am. Thank you. I would also like to thank the moderators, Dr. Ramesh Chowdhury and Dr. Rajendra Prasad. They have done an excellent job. They have moderated the session, and I mean, try to challenging task to summarize the questions and ask so that most of the questions could be asked. Because of shortage of time, anything it left out can be discussed in a subsequent forum. Thank you so much, Dr. Ramesh, and thank you, Dr. Rajendra.
Thank you.
And
Thank you, Professor Palan and no, sir.
at the end, let me thank you, distinguished delegates who are attending, joining us from 49 countries, giving an international flavor to the series.
Wow.
It is such a wonderful feeling to have all of you. And some of you are with us now here in Zoom and YouTube, and some are joining in the next few hours in the various platforms. So it is wonderful to have all of you with us, and may I again invite you to continue to join us in the upcoming sessions as well until we have the final in March. So the next session will be on 11th of November. It's we are again moving away from neurology to something that has been discussed again and again. Professor Manuel Sanchez Luna has already given a talk last year on the recent advances in HFO. Now he's going to enlighten us on 11th of November on the lung protective strategies in preterm neonates. So I welcome all of you for this series as well. And please continue to join all the series, and for interactions, please join our Learn from the Legends Telegram group, which the link has been already posted. The certificates for the series can be claimed with the link which that has been posted in the chat box, as well as you will be getting a reminder in that and for all the attendees in your email. So thank you so much. With all your permission, we wind up for today. Thank you so much. Thank you, ma'am. Thank you again.
Bye bye.
Thank you, ma'am.
Bye bye.
Thank you all. Thank you all.
Thank you. Bye bye.